Yeah, it's on a weird setting there.
Whoa.
There you go. Okay. So you get the corner.
All right, so this is the case given to me by Dr. Cohen. So what we have is a 26-year-old man who was just being checked for contact lens renewal. He's a moderate myope and had a problem that was noticed in his right eye. Medical history wise, he has history of ADHD, autoimmune reactions. He's on these systemic medications, lamotrigine, Retina, which is atomoxetine, vitamin C, omega-3 multivitamins, L-cysteine, vitamin K, magnesium, SPI, protect, bovine, olive leaf, and strigalis, which is like a some sort of supplement, like multivitamin supplement.
Is the olive leaf like a supplement, or he just picks one?
Yeah, so you can use these pointers, but you have to hold them low, okay, so.
His visual acuity is 20/20, and that lenses.
Use that one.
So it's 20/20 with no symptoms.
Okay, looks like this is fundus photo. Looking here at the left eye. And then looking at the nerve, mostly big sharp flat. Some tilting there.
Can you guys hear him on the internet?
Yes.
Nerve big sharp flat.
Okay. No, it's supposed to be a good mic.
Looking at the vessels, I think pretty normal tortuosity and caliber. Drawing attention to the macula. Get rid of this. There's some whitening sort of around the macula. It's a sheen, yeah. Okay. And then in the peripheries, looking at the inferior temporal periphery, we see gross abnormality here. We have discoloration, a white demarcated line that differentiates more normal retina. Superiorly, inferiorly, it's seeing paler color to the retina. Still seeing the vessels normally. And maybe some speckled pigment, speckled whitish dots, but no other pigment. Once see there. I think we'll keep going. Sorry.
Yeah, keep going.
You know, I wonder if you should point with the mouse. Do you want to, because can other people see the mouse? Can the internet people see the
I
mouse?
think the internet people can always.
Yes, we can.
We see the mouse.
Why don't you use the mouse?
That's what I was talking about here.
And then what were those little white spots you were talking about?
Oh, I just saw maybe some sort of dusting here, white spots.
Slow down a little bit, point. They say when you're speaking, you're not supposed to wave. You're supposed to point. And if you're pointing from a distance, stabilize your hand because you're a surgeon. Don't go like wiggly because nobody's going to refer your patients. That's all we know is start doing talks. Last thing you want to do is do a talk to a bunch of referring doctors and have
So these spots here I was referring to.
yeah, those are something.
Then I guess really distally, there's a couple more linear furrows. behind here.
Keep going here.
Okay, this looks like the same eye, just more zoomed out. Anything to add? We're seeing more, again, more of this distal linear furrows, I guess I'll call them again. Maybe a white spot here. Otherwise, that's the periphery. I don't see anything new to comment on.
What image is that?
This infrared?
Yeah.
Okay, again, with the left eye here, with IR image. Seeing a spot, is it reflectant?
Yeah, reflective.
Reflectant, so hyperreflectant spot essentially in the macula.
Yeah, that's an artifact.
Artifact,
Your,
okay.
your photographer can get rid of that if they pay attention. They just have to wiggle a little bit while they're capturing and you lose the spot. But
It is technically a reflection.
Reflectance. Okay. But then superior to that, there's
that's probably an artifact.
another artifact. Okay.
All right.
Okay, then looking at the vessels, I don't see any notable changes in reflectance. And then drawing attention again to the inferior temporal periphery, we see hyporeflectance distal to this whole linear change here. And then those white spots, I guess here would be hyperreflectant.
Show the people that line there, that little edge between the dark and the light. Can you put your mouse on that? That's on the IR. Sometimes you can pick up these little edges, which are nice to follow later. So that's one of the reasons I got the eye. Sometimes they don't show up, but sometimes they do.
Okay, now OCT image here, again, left eye. Looks to me like there's good foveal contour.
I should go back. I mean, what do you, I know you're new. Go to the color. What do you think's going on?
The detachment here.
Good, okay. And what makes you say detachment?
Just the nature of the size of this change here, the quality of the discoloration here.
Yeah, the 3D, yeah, Dr. Pavin has a way he says it, like 3D cues on a 2D image. And what are these lines? Do you guys know? They have a name.
Demarcation lines?
So that's a demarcation line. Does anybody know about how long it's, you guys can pump in here. Does anybody know about how long it takes to get a demarcation line? People have a date.
Months.
It's, I've read 3. I don't know where that came from, but I've always read it takes about 3 months to get the demarcation line. So things have to hold still. It's like a seaweed line. So so that means it's stopped here, moved, stopped, but now it's maybe moving a little bit more. That's why that little edge is of some importance.
Okay, looking at the OCT here, so I think the foveal contours within normal limits. The architecture looks pretty well organized. Maybe just a few areas of hyporeflectivity, maybe artifact or relevant.
So Nabeel asked.
So those are just the vessels.
Vessels, gotcha. Mhm.
Yeah.
And then drawing our attention to the left side of the image. I don't know if this is subretinal fluid or this is playing towards the nerve.
So, yeah, you think it's a vertical or a horizontal?
Look at
The area that you're, it's vertical, right? That's the right side.
Yeah.
Gotcha. Okay, so it's not, that is heading towards the area of concern. It appears to be lifting off the neurosensory retina, appears to be detached from the underlying cortex. Good RNFL layer here. And maybe some base posterior eyelid detachment here.
Well, is it?
That's a premacular burst, so that's
Premacular
normal.
Yeah, where's that? You can see the posterior eyelid if you put your arrow
here.
right there. So it's lifted off just a little, but that's actually some also important surgically.
So you don't know if there's a PVD or not.
Okay, looks like we're zoomed in here on the OCT, and again, well, my attention is drawn here to the right side of the image, so we're seeing some separation of the layers of the retina here from the underlying choroid.
And then up in the corner, that squiggly, that stuff over there, what do you think that corresponds to in your color picture?
Is that some of those spots we're looking at?
That's probably the demarcation line. That's the line. You're probably catching the demarcation. It's a little subretinal fibrosis. It's interesting, they do lift off with the retina, so they're more, it's not RPE, it's more retinal.
Yeah, so
So I guess it's been a few months, we're thinking more like a chronic RD, like a young patient, myopia. So, yeah, I guess rhegmatogenous versus less likely serious fractional.
Okay.
Yeah, I think these like pregnancy is kind of unlikely. Here, we can see where the detachment is.
Yeah, the OCD is helpful for that.
You know, another way you could tell, like if you're doing laser. Between the retinal pieces and retinal detachment.
I don't think.
The retina skeezes, if you shoot it, it still makes a white mark because the neurosensory retina is still attached. And if it's elevated, if it's actual detachment, when you shoot through, you won't be able to hit like the RPE through the fluid.
So I'll just give kind of a brief overview of retinal, actually, we can summarize findings.
Okay.
So, you wanna go ahead?
Sure, so the patient, the 26-year-old male, myopia, bottom disorders, presenting with actually normal vision, and found on left eye exam to have an inferior temporal, with good to be chronic, rhegmatogenous retinal detachment, and with a demarcation line that may be advancing based on some of the features.
And the little white spots, let me know what those are.
Liberated or
It's probably shed photoreceptor outer segments. Sometimes in attachment, you get, I think that's right, you get those little white things that attach to a detachment. Sometimes you see them in central sturs too, I think. But in rhegmatogenous attachments, there are little white spots under, which are probably photoreceptors. And then was he symptomatic?
No,
No, okay, so this was picked up on exam. So that's important with surgery.
yeah, and another thing, no PVD, no apparent
Right.
tear or break. A hole. I didn't see any lattice and
He did have a hole. He did have some lattice in the hole. I can get it in the photos.
yeah, it was in the photo.
Yeah, but
Yeah.
yeah.
I was assuming the photo, yeah. Alrighty, so kind of just a brief overview of RDs, because go on for a long time, but there are three types. You have rhegmatogenous, tractional, and exudative. Tractional typically from diabetes or sickle cell, due to neovascularization. Rhegmatogenous are due to a tear or hole in the retina, and that allows fluid to get beneath the retina because of the detachment. Exudative are usually used due to some underlying inflammatory process. And then the way you can tell the exudative, typically the fluid wave kind of shifts. If you have the change in position, you can see the detachment move around. So risk factors, the biggest risk factor for retinal detachments is lattice degeneration. And then next is the peripheral retinal breaks and pathologic myopia. If they've had any previous intraocular surgery, any trauma, previous retinal detachment, if they have a family history of retinal detachments, find a separation of the neosensory retina from the RPE. Most typically, rhegmatogenous retinal detachments occur from retinal tears, which are associated with posterior vitreous detachments, trauma. Surgically, the most common cause of repair failure is PVR. And then risk factors for PVR is age, giant retinal tears, retinal detachments involving more than 2 quadrants, previous retinal detachment failure, use of cryotherapy, which is total detachment trauma. So some of the key things you want to look for exam when you are considering a retinal detachment, you always want to look for initially on your slit lamp exam, Schaefer sign and pigment within the AC or the anterior vitreous slit lamp. And then one thing you can also always check for is if there's a PVD. Then the next thing you want to do is a press thorough examination. You want to see if you can find any holes, tears. And then you want to measure out or figure out the clock out, except for retinal detachment's at. And then most importantly, you also want to know if the macula is involved, because that's important surgically.
And then for Schaefer sign, it's 100% correlated for phakic patients with a tear, but for pseudophakic, it doesn't necessarily mean that much.
Someone told me once that an anterior vitreous artery
Oh, because the pigment definitely needs a tear. And then the blood needs, I think it's 30%, 20, depends on whether they're on blood thinners. Actually, I did a paper with one of the old residents on that. If they're on blood thinners, there's a 40% risk of a tear. If they're not on blood thinners, there's a 60 to 70% risk of a tear. If there's blood, but if there's pigment in their phakic, it's 100%.
When you're looking at the anti-visuals on the program, I always thought of that was on the belt, but is that, how do you distinguish pigment and
Oh, the pigment looks, the pigment looks a little brown. Looks a little brown. And the other thing, the way to do the anti-vitreous exam is have them look up, down, and then straight. So if you just look straight, I don't think you really get credit for that. So what I do is you have them look straight, you look in there, you're not gonna see very much. Then say look up, look down, and straight, and everything's like all over the place. You can look for stuff.
And Dr. Cohen, that the rates that you were quoting for hemorrhagic PDD, somebody told me it has to be a significant amount of heme to qualify as 70% rate of tear in somebody without blood thinners, or do you say any amount of heme in somebody with a PDD?
The
It's
big
not
one
on
we
the
did was Annie.
Okay.
We did it was Matt Whitmer, 10 or 20 years ago, but we counted anything.
Okay.
How many eyes were there?
We had over 100. We had like 150 of them. So which is decent. We had the most biggest group. Pretty proud of that. But
Yeah.
we had pre-medical records, but we had a pretty big group. I don't know, since then, I don't know, 3 electronic records. Yeah, he was going through a pile of records. With the paper.
History wise, you always want to apply to his floaters, any threatening of the vision, and loss of any peripheral part of the vision. One way you can separate retinal detachment from retinal schisis is retinal detachment have a relative stechoma, and retinal schisis absolute. So in terms of management, first thing is you want to identify all breaks, and then you want to treat those breaks. Those breaks can either be treated with laser or cryotherapy, but you have 3 main surgical options. Pneumatic retinopexy is one option that can be considered if the retinal detachment is due to retinal tears in the superior 8 clock hours and involves a single break less than 1 clock hour, or so the detachment's in the superior 8 clock hours and the break is less than 1 clock hour. Second thing, the oldest is the scleral buckle, and then thirdly, you can use parclinic vitrectomy. It can be used, scleral buckle vitrectomy can be used together or alone, and then in conjunction with laser or cryotherapy to treat the tears. And then actually another option as well is you can laser if you have a shallow attachment or a smaller attachment, you can put the laser around that attachment to the donor.
You can laser demarcate. Be careful though. You can, and I actually had a medical doctor I laser demarcated at least recently, but I generally, if it's past the equator. Do the other attendings have guidelines for when to laser? Scott, it looked like you were about to say something.
I tend to laser, it depends. Definitely when it's close to the arcade, I will not laser. So if I feel like they're going to be symptomatic from the laser because it's too posterior, I won't. But I don't really tend to laser that much. I'm pretty liberal with my pneumatics. So it is with this patient, say this patient was symptomatic and you're seeing a demarcation line and the subretinal fluid has extended. What factors would you consider in this patient in planning your surgery?
You could do a more senior resident. Either pick up or whatever they can. Could you repeat the question or all of it? Oh, go ahead, say that one more time.
So say this patient was symptomatic. You can see that the subretinal fluid has extended because you see a demarcation line, but the subretinal fluid has extended past and he's symptomatic. What factors would you consider in this patient in planning for surgery?
Well, he's young and phakic, so you might be more considering doing a buckle in this case, because if you're doing like a vitrectomy, especially if you do silicone oil, he's gonna end up with a cataract. which you're then gonna need to do surgical planning for later on. So if you can do a buckle and, you know, relieve the traction,
Mhm.
especially with how young he is, probably a good idea.
Yeah, I agree. And looking at the OCT, you can see the posterior hyaloid is pretty firmly attached. So it would be pretty difficult to be able to induce a PVD to try to remove the vitreous. So that's another consideration too. But yeah, I would do a buckle on this patient. If he's
Without symptoms,
asymptomatic,
yeah, go ahead.
Sorry?
Without symptoms, would you take him right to surgery?
no,
or-
no. Without symptoms, I'd watch him.
Okay, anybody else? It's a tough one.
Yeah, I would operate. He's young. I would do a buckle. And I use laser when patients are commonly bilateral. One eye is worse than the other. And you look in the other eye and you see a peripheral detachment further out. And that's where I would use laser. I don't like doing buckles on both eyes. And mainly because I'm just lazy. It's just a lot of work. And so I would do laser on one eye and then I would buckle this eye. And usually they do quite well. You really, vitrectomy is just fraught with complications in these eyes. If you have to do it, you have to do it, but you're going to get a cataract. You're not going to get a complete PVD. When you try and get that PVD, you may get some bleeding, some more retinal tears. It's just a mess. And yet it still usually works. But yeah, he's so young. I don't think you should just be watching. I did do one patient who was probably in his 40s, 30s or 40s, and I did do a fairly posterior laser on that patient, and I always felt that I had inadequately treated him in the second eye. It was the second eye, buckled one eye, second eye. But he came back several years later and he was still holding. So, laser works.
And you really had no field defect at all?
I'd ask him. Sometimes you can elicit. I don't think I elicited him. It's like, give it up here, like he's.
Do not ask. Do not ask.
You can find.
Do not ask a question you don't know the answer to. That's the first thing a lawyer learns.
Anybody else have either surgery or no surgery?
Oh, sorry, I was driving. So
Okay.
whenever I see the demarcation line, it doesn't mean that it protects not progressing to retinal, to more retinal progression of retinal detachment. It is said even with demarcation line, 30% of the patient, we may have progression of retinal detachment. It doesn't mean that it protects and it's a barrier. So I always treat those patients if it is not through this diameter on posterior to equator. I do laser. If it is progressed more than to this diameter than the equator, I usually do buccal, specifically if the patient is phakic and young.
Okay, thank you.
Yeah. So anytime you do any sort of, you do surgery for retina or retinal detachments, you have a risk of cataract formation, glaucoma, bleeding, infection, choroidal effusion, cystoid macular edema, macular puckers, double vision, especially with scleral buckles, and then refractive shift and proliferative vitreoretinopathy. So like we were just discussing, this patient is completely asymptomatic, and would it be treated any different, or should it be treated any different? Luckily, Dr. Cohen wrote a paper on this.
We're not gonna spend too much time. It's a hard paper to find, but it was 16 patients, and they all did fine.
Yeah, so the study includes 16 patients. They all had rhegmatogenous retinal detachments, and they extended greater than 2 disc diameters posterior to the equator. Followed these patients for an average of 46 months, checking if there's any progression of the retinal detachment, or if it became symptomatic. Of those 18 patients, or of the 18 eyes, none of them progressed or became symptomatic. But key things to consider is all those patients had retinal detachments in the inferior temporal quadrant, like this patient. All had partial demarcation lines on presentation. Only 3 of the 18 eyes had firm retinal tears. There was no acute PVDs or no PVDs occurred during that follow-up period. There was a few eyes that had previous PVDs, but nothing acute happened during this follow-up period. And the patients are relatively young also, it's average age of 57. So the conclusion was that they could probably be safely monitored for many years. But that still doesn't address the difficult question that you can have when you have asymptomatic pragmatized retinal detachments, and that if you're ever considering cataract surgery for these patients or any sort of ocular surgery, what's the risk of that progressing or causing a progression? And if there is an acute posterior vitreous detachment, you know, how does that change things? Or there's any other unusual situation? So this is a 1-month follow-up.
So what do you see there with your mouse? You're back on.
1 month.
So the old one's on top and the new one's on the bottom.
Okay, doesn't appear to have improved too much here. I'm still seeing a lot of subretinal space here, subretinal fluid.
Does it look the same?
Look
better,
at,
or
look at the
worse?
landmarks of where the vessels are. The vessels are the same, is it progressing?
Oh, I see.
50-50.
Yeah, it is progressing, right?
There you go.
Yeah, this one's progressing. You know, it's nice. OCT is really nice. You know, you could probably have figured this out with pictures, but the OCT, you know, you get this 10 micron resolution and you can watch things a little bit. If you look on the back of the retina, you can kind of see the little serrated dots, the little photoreceptor things on that. But yeah, so this definitely progressed.
Yeah, in the next picture, you will definitely progress there. Just looking at the vessels where the bifurcation happens, you can see it's closer there. That like little area of edema. The little area of edema is the same, but the detachment also looks like it's progressed there.
He's still asymptomatic at this point?
Yeah,
Yeah.
place in back. He also has his wedding coming up in 3 months.
So would you change your management, given the fact that he's clearly progressing despite him being asymptomatic?
So,
Me or the residents?
Anybody?
I'd see him once a month until the wedding, and then right afterwards, I take him to the OR.
So you're
Yeah.
gonna,
Quick
Ruin the
honeymoon.
honeymoon.
let's say
Quick honeymoon,
you're
after the honeymoon.
off the day before the wedding, you're like, all right, it's
And
all
then,
right.
Yeah.
then he can see 2 of his wife on his
I
honeymoon.
figured the blood, I think 3 months was enough. I mean, my eyes
Yeah.
were pretty beat up. By 3 months, I think the pictures, a little Photoshop, they'd be okay.
Yeah.
Just wear
Yeah,
sunglasses.
at this point, I would definitely treat him,
Yeah.
even though he's
so-
asymptomatic. Yeah.
Underwent sclerobuccal with cryo, the retinal fluid drainage. Just a post-op photo. You can see the retina's kind of back into place, still a little bit of a gap there, but basically in place. After the buckle. And.
Sure. So now, looking at this fundus photo, it looks like we see a lot of the normal coloration of the retina returned and the area where the detachment was previously. And I don't see as much of that, you know, subretinal fluid by the demarcation line, so it appears to be reattached.
This is an interesting older, younger doctor thing, but would you guys, would everybody have drained this? Drain the subretinal fluid? Or
I would attempt to drain it, but the subretinal fluid tends to be pretty thick because it's chronic. So I wouldn't be so adamant in trying to, you know, get rid of all the subretinal fluid. Basically, you want to just support the breaks, and it can take several months for subretinal fluid to subside. But what you're trying to do is to prevent any further progression. So if you have the breaks supported, you should be fine.
You probably could have gotten away. The drainage is the dangerous step, you know, because buckles are pretty safe, honestly. But sticking in, I do a needle drainage. I don't cut down anymore, and you know, I'm pretty good at it now. But you know, you can get bleeding anytime because you're going through the choroid to the subretinal space, no matter how you do it, and you get a hemorrhage. I almost always drain. The old paper suggests that you probably don't need to, which is weird. But the couple times I did it when I first started practice, that they all failed, so now does anybody not drain still, or?
Well, it also depends on how, if it's a low lying detachment, if there's not a lot of fluid, I probably would not drain.
Yeah, this was kind of a mix. This was chronic. I think chronic, you're supposed to drain. Low line, you're not supposed to,
Yeah.
normal. It was sort of like.
I would attempt to drain this one.
What I do is I pull the buckle up and then to decompress the eye, just stick the 25 subretinal in. It decompresses the eye and drains the fluid.
If you don't drain, is there any complication? Does it just stay there or does it self-resolve?
It's self-resolved.
Okay.
Which is weird. It doesn't make sense. Because you're not really, there's a physics thing, there's this, the flow through a tube is the third power, the resistance to flow of the. Yeah, there's a power thing where if you close the space a little bit, you get a lot more resistance to flow, and then the fluid can absorb. But you also relieve the traction.
Did he have any
But
pathology?
sometimes it could take up to a year for subretinal fluid to resolve.
Yeah, an OCT. That's why the OCTs are interesting. The OCT, even subfoveal fluid can take a long time. So that's the thing, and not so much on buckles, but on pneumatics. So if you pneumatic somebody and you get the subretinal detachment, you get this pneumatic a superior bolus detachment, you get this inferotemporal persistent detachment. That's probably just fluid. And you just watch it and watch it and watch it and watch it. And over the course, and that's where OCT is really nice. So you watch it, it's getting a little better, good. If you watch it's getting a little worse, like there's probably a tear there. So OCT, but yeah, the fluid can take forever to absorb. Cool.
Do you ever have a hard time selling these people in surgery?
No, I'm pretty good. I can't sell anything, but surgery, I had a guy yesterday. So it's always risk benefits and alternatives of not doing surgery versus risk and benefits of surgery versus risk and benefits of not doing surgery. So it's that's always your conversation. So there's always a risk, and it's never 100% either way, which everybody wants. Everybody wants everything black and white. So there's a risk and benefit of the surgery, the risk and benefit of the watching. And at a certain point, macula and retinal attachments have a 95% chance of having good post-op vision. Macula off retinal attachments have like a 10% chance, I think, of normal vision. So you're looking at that as your benefit. If your risk of surgery, there actually was a paper came out around the time of mine on surgery for asymptomatic retinal attachments, and they had a 10% complication rate. So you probably have about a 10% complication, but most people want to know about catastrophic. I can go on. Most people want to know about with catastrophic complications. Catastrophic is more like 1 in 1,000. What's the risk of a anesthesia? Something horrible with the bleed or the needles or the God knows what. You cut into the eye, and because most things there's the complications of surgery, and then there's the chance that they're not going to subsequently be fixable. So I think the risk of complications is probably 5 or 10%. The risk of a catastrophic complication is probably 1,000. So that's the surgery side. And so anyway, so that's what I was like, risk and benefits of not doing surgery versus risk of surgery. We had a guy yesterday who was a post-op diabetic with a retinal attachment on ultrasound and vitreous hemorrhage. He did not want to go back for surgery. And it was really slowing me down. Patients, and I just kept them in the room, and I said, get a second opinion, do this. It's like, I just don't want you to leave your eye, because for reops, it's hard, because what he said, which is logical, is they say, if the first surgery didn't work, why should the second one work? Which is a somewhat logical thing, but it's just not valid. Oh, so nice job.
I saw another study too on, it was from the UK, where they surveyed like retina surgeons on like 6 different cases and whether or not they would operate or what they would do. And it's the most similar case to this one. Most of them still, like I think 60 or 70% said they would not operate.
Yeah, most people operate. Most people, we're a little bit outliers. That's why I'm an out. Most people operate asymptomatic.